It's a pleasure to welcome you to this fourth Global and National Burden of Disease session. And we have 4 speakers who will have 15 minutes each. First, Donald Schopflocher of University of Alberta will present results of an empirical evaluation of the independency assumption in comorbidity estimation. Then Theo, who is a professor at IHME and University of Washington and a core member of the GBD 210 team, will also present on comorbidity issues. Michael Wolfson of the University of Ottawa, he will present results from a simulation study of determinants of health-adjusted life expectancy. And finally, Nicole Jones, with new data series established at IHME, will revisit the classical question of income or wealth inequality and population health indices. So we take all, as before, all talks without interruption, and then questions. So, Don.
I was very privileged to be able to spend a sabbatical in 2012 in Wellington, New Zealand, working on the New Zealand Burden of Disease study conducted by Martin Tobias, and which Martin briefly described yesterday. Data presented here are derived from preliminary disease prevalences and disability weights for 217 diseases from the New Zealand Burden of Disease study, with some health survey data from Canada and from New Zealand. To review briefly, here is the way in which YLDs are calculated from a prevalence perspective in burden of disease studies. Disability weights are assumed stable over the duration of the disease state, and as you know, the methodologies for determining disability weights have evolved considerably in recent years. However, methods to determine overall disability weights for individuals who have 2 or more diseases are not fully evolved. One solution might be to use current methodologies to estimate the disability associated with combinations of disease. This quickly might become very unwieldy if individuals are asked to judge diseases in combination. Various modeled solutions are possible, though. Simply adding disability weights together, unfortunately, sometimes leads to impossible disability weights, though that is weights greater than 1, and is unrealistic even when the sum is considerably below 1. At the other extreme, ignoring the disability associated with the less disabling of 2 or more diseases does not seem realistic. Colin Mathers and his colleagues from Australia proposed a method of combining disability weights that is less than adding them together, but guarantees a resultant disability weight less than 1, no matter how many diseases are present. This formula also generalizes to combinations of multiple disability weights. In the first line of the formula, if we simply add bracket 1 minus disability weight C and bracket, that would be the correction for the combination of 3 diseases for an individual with those 3 diseases. Once a method of combining disability weights is chosen, a method of estimating comorbidities is required. Typically, that is involved assuming that diseases are statistically independent and performing simulations according to the steps on the slide. That is, would generate a simulated population using empirical prevalences, calculate individual disability weights on that population using Mather's formula, average the disability weights across all simulated diseases, and then adjust the disability weight either individually by disease or by an overall reduction constant, depending on the nature of the aggregation. This graph shows results from simulations using provisional data from the New Zealand Burden of Disease study. Here, there are results from 11 age groups, age group specific simulated populations of 250,000 simulated individuals each, where each individual's disease profile contained 217 that is present absent disease scores, simulated to match the empirical prevalences of the 217 diseases in the New Zealand study under the assumption of independent or uncorrelated diseases. The upper graph shows, the upper line shows the sum of disability weights, and the lower part of the graph shows the the sum of the independent correction, and shows that the corrections are increasingly important as age increases and as the overall prevalence of disease increases. So they range from about 5% at the age 35 to 39 in this diagram to about 28% in the New Zealand data at ages over 85. But what happens when diseases are not independent? First, let us consider the extent to which an additional adjustment may be necessary. Let's begin with a simple two-disease model where the cross-tabulations in a hypothetical population of 1,000 people is given, in this case in Table 1 on the left. Notice that in this situation, there is no tendency for a person with a disease A or B to be more likely to have B or A than a person who does not have these diseases. That is, there is no association or correlation between the two diseases. Let's assume that the disability weight for each of the diseases, A and B, is, for example, 0.1. Then the disability associated with both disease A alone and disease B alone is 0.1. Under the model we're assuming, the disability associated with both diseases together is 0.19. This is slightly less than would have been the case if the disabilities had been additive. It would have been 0.2. Therefore, the total YLD in this population is 19.9, which is the sum of the different disabilities in each cell, of course assuming that there's no disability associated with no disease at all. Note that simply adding YLDs of the two diseases would have given us a total of 20 YLDs. Now, let us consider how to represent a situation in which there's a tendency for disease A and disease B to occur together. This is illustrated in Table 2 on the right. We need to recreate our table in a way that the population remains the same size and the number of diseases in this population also remains the same. We can accomplish this by increasing the number of persons with both diseases by 1, decreasing the number of individuals with only one of the diseases by 1 for each disease, and consequently by adding one more person to the cell with neither disease. Note that we have not changed the prevalence of either disease or the size of the population, only the tendency for the two diseases to co-occur. Now, the total disability in the second table is 19.89. There has only been a very slight decrease in the total disability because the disability added by the individual now suffering two diseases is more than offset by the loss of disability from the one who no longer has either of the diseases, though only slightly. The overall decrease in disability will depend upon the degree to which diseases co-occur and the size of the disability weights, as well as the size of the population. The higher the ratio formed by the number of individuals having both diseases divided by the number that would have been expected by chance, a measure that Mathers and his colleagues called the comorbidity ratio, the greater will be the decrease in the population's disability. And the higher the disability weights for the two diseases, the larger will be the difference between the combined disability and the sum of the individual disabilities, and therefore, the larger the reduction in population disability. But now we'll consider the extent to which diseases are actually correlated, and then consider the extent to which these correlations may reduce YLDs. We began with 2 health surveys, the New Zealand Health Survey 2006-7, with almost 21,000 respondents, and the Canadian Community Health Survey in 2008, conducted by Statistics Canada, with almost 131,000 respondents. The questions we're concerned about, both of these surveys were quite long, were of course related to suffering of diseases, and they were quite similar, although since the surveys are self-report, the usual caveats apply to the validity of the estimates of prevalence. There were differences in the diseases about which questions were asked and in the age groups in which data had been assembled, necessitating some data reorganization. Identical final data sets were created for each survey with 7 10-year age groups from ages 15 to 24 through to ages 75 plus. The 7 diseases where we had data in common are given on the slide. In the New Zealand Burden of Disease Study, these are high prevalence conditions responsible for a high number of YLDs. The top 3, 5 of the top 6, and 7 of the top 11. First, we modeled the relationships between the 7 diseases using a log linear analysis. We discovered, this was in the Canadian data, we discovered that a model with all 2-way interactions was a very good fit, though not quite perfect. A model with some 3-way fits, interactions was slightly better by the likelihood test, but then we did have 128,000 subjects. However, the fit using the 2-way interactions only suggested to us that the relationships between diseases were not strongly affected by which other disease was also present. As a result, we continued our analysis by switching to a correlational framework. We calculated Pearson product moment correlations, and these show that the relationships between these diseases as reported in self-report were modest. Then we conducted a principal factor analysis, principal axis factor analysis, to determine whether the pattern of correlations was similar between the 2 countries. I'm showing here the largest factor, which accounted for about 20% of the variation in the 2 countries. And overall, there was substantial similarity across the countries, as shown by the pattern matching coefficient, which has a maximum of 1, essentially a correlation between the loadings. The loadings themselves are estimated correlations of diseases with a single underlying latent variable and can be used to recreate the underlying correlation or covariance matrix. In order to determine whether the nature of the comorbidity changed with age, these analyses were repeated within each age group for the Canadian sample, and factor scores were calculated at each age and on the overall samples, and correlated with the conclusion that there's little evidence that the extent or pattern of comorbidity varies by age. The next step in our analysis was to create simulated populations whose disease profiles reflected the empirical correlations between the 7 diseases that we had examined. Again, we generated age group specific sets of 250,000 simulated individuals where each individual's disease profile contained 7 present absent disease scores simulated to match the empirical prevalences of the 7 diseases under the pattern of correlation implied by the factor analysis. Along the way, we created a method to accurately simulate such correlations in binary data, but that's a story for another day. Then, taking the simulated populations from our earlier simulations, we replaced the 250,000 individual profiles of these 7 diseases with the newly generated profiles of the 7 diseases, leaving the rest of the profiles intact. Then we calculated the reduction in YLDs using the procedure we had previously outlined, with now, of course, some correlated diseases. The further reduction in YLDs beyond the reduction from the independent comorbidity was small and ranged from 0.2% to slightly over 1%, and increasing slightly with age. Now, before you offer the criticism that we have only introduced correlation among 7 of the 217 diseases, let me describe our further findings. First, the 7 diseases we were operating with account for 30 to 38% of the total recorded YLDs, and that proportion is decreasing with age. Second, an average of slightly over 100% of the reductions in YLDs were found in the changes in the 7 correlated diseases alone. In retrospect, we might have anticipated this, but I didn't. But this allows us to look at the percentage decline in just those 7 diseases rather than a percentage decline in the entire set. When we isolate those percentages, they turn out to be, on average, very close to 3 times as high as the percentages shown in the previous graph. However, even if we assume that all 217 diseases were intercorrelated to about the same extent as the 7 diseases that we examined, which I believe is highly unlikely, the further reductions beyond that calculated from the independent comorbidities due to dependent comorbidity would have been about 0.6% to an upper bound of about 3%. Yeah. First, we've created a system where we will be able to simulate dependent comorbidity change given full or even just partial covariance matrices. So we can use a simulation framework if we can create covariance matrices. Second, I think that we may be able to safely ignore corrections for dependent comorbidity, at least in YLD calculations from developed countries. They're substantially lower than the corrections for independent comorbidity. We may be able to get a more definitive answer as we embark on a burden of disease study for the Canadian province of Alberta over the next couple of years. Because of Canada's comprehensive healthcare system and following New Zealand's and Australia's, I learned, lead, we will be attempting to construct actual disease profiles for our approximately 3.7 million citizens that will provide the potential for estimating a full set of dependent comorbidities to further enhance our understanding. Thank you for your attention. I'd also like to thank the sponsors of this work as noted here.
Thank you.
Thank you, Donald. I have a bit of a reputation of trying to be provocative or controversial when I talk, but I think I'll find it hard to find any controversies compared to Donald's talk, as you'll see that the findings that we had in our global burden of disease study on comorbidity closely mirror the statements that you've just heard. So let me take you through that, through a different type of analysis, but with very similar conclusions. So we examined the medical expenditure panel surveys in the US in quite a bit of detail to look at the issue of comorbidity. And so I'll tell you quite a bit about that, and then how we use the information from that in our overall comorbidity simulation for GBD 2010, which we've dubbed COMO. So MAPS is an annual panel that's being started in the US. We're then followed up over 2 years with 5 data collection points for the panel. Most of the focus is on collecting information on health expenditure, and any sort of health service contact, including collecting drugs. But for each of those contacts, diagnostic information is gathered. We have a time series from 2000 to 2009 that we could analyze with close to 200,000 observations from more than 100,000 individuals, with enough diagnostic information that we could map it to 158 of our GBD disease and injury categories. And the interesting thing was that there was additional information on health status by individuals using the short form 12, SF12, and that was done twice in each panel over the 2-year period that they were being surveyed. What we then did was try to look at a crosswalk between SF12 and our disability weights. To do that, we used a total convenience sample of 60 IHME staff who, at least at the time, had not yet worked on GBD. And we asked them to fill in SF12 for 50 out of 60 health states that span the spectrum from very mild to the most severe in our disability weight surveys, and then ask them fill in SF12 for an individual that fits the lay description. After excluding a proportion of answers that were further than 2 standard deviations removed from the median, we then fitted a Lewis regression on the remaining SF12 scores and their disability weights. And you can see that there was a reasonable fit with the SF12 scores at the bottom and the disability weights on the y-axis. We then, once we had a method to translate SF12 scores for individuals and translating that into a disability weight for each individual in those surveys, we then looked at a way of parsing out the combined disability weight to what the disability weights were for each of the contributing comorbid health states. And we used a similar multiplicative function for that, and then used a mixed effects model with a logit transformation of the dependent variable. And the logit transformation has a nice property that you never go beyond 0 or 1, and it also implicitly defines a multiplicative relationship between the independent parameters, and that is consistent with our multiplicative model. What we then did was put it into a logit regression where we have beta coefficients for each of the existing comorbid conditions, and added a U term towards the end, which is a random intercept to deal with the fact that there are multiple measurements on the same individual in the MAPS data. So that allowed us to measure severity in GBD disability weight terms for any condition in an individual while controlling for all other conditions present. And a number of interesting findings from this. First of all, when you plot here the coefficients in logit space in a model that includes age on the y-axis versus a model that ignores age on the x-axis, you see that all those points are very close to the line of unity. And but the conclusion we drew from that was that as long as you account for all existing comorbid health states, age is no longer a very important predictive factor. We also, once we'd done the analysis disregarding age in our models, but then multiplied up using the same multiplicative function from the predicted weights, the total disability for individuals was, and then averaged that across the whole population. And you can see that there's a rather close relationship in these age-specific estimates between the observed in the data, what we directly translated from SF12, and what we predicted with our model. Of course, there's some circularity because we used a multiplicative model to derive these individual disability weights, but the fact that we can replicate the age pattern is at least some justification that a multiplicative model seems reasonable. Then, same issue as Donald was talking about, the difference between dependent and independent comorbidity. Well, have a look here at diabetes, where we would expect major impact of comorbid health states, given all the dependent relationships between diabetes and, for instance, all the cardiovascular outcomes, but anything that is associated with high BMI. And you can see that there's almost no difference that we can find when we take into account these dependent relationships compared to what we would do if we only look at independent comorbidity. A few more examples along similar lines. The graphs are smaller, but the whole point is that even for other conditions like depression or COPD, where we would expect quite a bit of dependent comorbidity, we don't see a lot of it. Maybe a little bit more towards the higher end of the spectrum for depression and COPD, but not a lot. And for conditions where we wouldn't have expected that much, you see it's almost exact unity between the dependent and independent models, for instance, for asthma and migraine. So, overall conclusions. As I already said, age is not a big predictor of comorbidity, as long as you have enough diagnostic information of what the comorbid health states are. The multiplicative model seems to work. There's at least some justification in the data that I've shown you. And that after correcting for independent comorbidities, adding dependent probabilities of co-occurring conditions makes little difference. When we saw this, we said, "Youppi," because trying to think of all the analytical work needed to populate a matrix between 1,120 health states and what the dependent correlations are between that was mind-boggling. So it was very convenient for us to be able to ignore that. So how did we do that? I think you've already seen the method of how you use a multiplicative model to get a combined weight between two health states, and how you then parse it out in an individual to a lower value for each of the component comorbid health states, as indicated by this graph with the guy with the IHD gloves and shorts and the stroke leggings. From a population perspective, how did we deal with that? We set up, and this was based on the methods that we developed for the Australian Burden of Disease study of 2003. We did a huge simulation creating hypothetical populations for each age, sex, year, country category, and we did 10,000 for each, and if you multiply that up, that was 250 million people generated in this simulation. Then for each individual, based on the prevalences of the 1,120 health states, using them as probabilities, we determine who has no health state, who has one, who has two, who has three, and who is the poor bugger who has n comorbid health states. We then use the multiplicative function to get comorbidity corrected, total disability weight for each individual, then parse it out proportionately to each of the health states that an individual has, and then across every prevalent case in each of the cells of our microsimulation, we average the disability weights for a health state after all the corrections and get a comorbidity corrected disability weight. And these are our findings. We went up to 80 plus as opposed to the 85 plus you saw, our findings go to about a 15% correction of estimates in the highest age group, which is quite a bit lower than the 28 or 29% that you mentioned. We should explore where some of the differences may lie. You can see it's relatively minor at the youngest ages, and progressively, as you would imagine, with many more comorbid health states, it increases with age, and it is. It's not a major adjustment, but it is big enough for us to have cared and to have made the corrections. So overall, it was very useful new insights that we got from doing this analysis of the MAPS database, and it was so useful because it's so rich in diagnostic information and combining that with health status information. We'd like to replicate this in other data sets, particularly in low and middle income countries, and it looks like there's some promising surveys that we've recently found with people we're working with in China and Turkey. One last statement is that the decision to more seriously address comorbidity was the most compelling reason to choose prevalent YLD over incident YLD as we have done in the past. Because just try and think of how it works if you have to do a proper comorbidity correction on future streams of ill health, which you do with an incidence approach. So just showing it here, if there's incidence in a particular year of interest, and you've got 4 different conditions indicated by the bars with different colors. Each of them with a different duration, you would have to keep track of that. And this is just for one single individual. Over each time period, how many comorbid health states there are. Try imagining having to simulate that across the 250 million people, taking all the permutations into account between over 1,000 health states. It'd be mind-boggling and hard to conceive how to do it, and computationally impossible. So that was a big reason for us to, among others, to give preference to a prevalent YLD approach. Thank you.
Hello, I'm really pleased to have the opportunity to present something a little different. We're going to be big data, lots of information. This is work that I've been doing with my co-author, Jeff Rowe. It's an ambitious effort. It's nowhere near as big as the GBD project, but it's pretty large. It pertains to Canada, and it's unique in that it's benefiting from a nice longitudinal health survey. Our goal is to assess the relative importance of different health determinants for health-adjusted life expectancy, or HALE. I want to go well beyond the usual approaches using population attributable fractions and categorical attribution. We're drawing explicitly on micro-level data in order to build up full life course trajectories or biographies of individuals. And we're going to focus on functional health, so this is very different from the GBD approach with its 1,100 sequelae. We're going to focus on 8 functional health status domains, and we're going to skip over disease entirely. Theo said something about not wanting to be provocative, me neither, right? We're also going to incorporate comorbidities and competing risks explicitly by estimating not just one statistical relationship, but a whole family of dynamical relationships that tell us about the co-evolving patterns of risk factors in functional health domains. This is a massive statistical exercise, but not to worry, because we're going to plug the results into a micro simulation model. this is just a little change of pace. I'm disturbed sometimes in conversations where people throw around the word model, and I think it should always be preceded by at least one other word. So I'm not going to be talking about a fashion model or a mouse model, but rather I'll be bouncing back and forth between regression models and simulation models. The general plan of what I want to describe to you is the statistical analysis of the NPHS, a longitudinal data set. Every second year people were interviewed, and we're using the data from 94 to 2008. We're going to run many regressions, and we will then plug them into a simulation model to generate these synthetic biographies. The cohort that we're generating is kind of a semi-period cohort because the transition dynamics represent what's going on over a decade and a half, from 94 to 2008. Once we have this baseline cohort, we can then create variant cohorts in the simulation model by snipping various causal pathways. We create counterfactuals to see how much difference the snipped out part really makes to our bottom line. We've already heard a fair bit about measures of health status. I confess when I come to Seattle, I have to think upside down because the functional health status measures that I'm used to worrying about in the Canadian health surveys use the health utility index where 1 is fully healthy and 0 is dead, rather than the reverse as it is with the YLD and things like that. And indeed, there's states worse than death. There are 8 dimensions in this McMaster Health Utility Index: vision, hearing, speech, mobility, dexterity, cognition, emotion, and pain. And there is a weighting function based on community preferences, elicited in a fancy method with standard gambles, that allows us to aggregate these 8 categorical variables into a summary index. I suppose most of you already know what health-adjusted life expectancy is. It's a way of taking the standard life expectancy, but somehow correcting it for how healthy those years of life are. The standard method for doing this is called the Sullivan method. It relies on a kind of life table type matrix type stuff. But let me emphasize that the Hales that we're going to look at here are not at all like that. They're based on simulating millions of individual biographies and then building it up from all of those individuals. And given that Dean Jameson yesterday afternoon mentioned dashboards, I don't want to sound like we're preoccupied with just a single index because we have a full underlying microdata foundation. We can construct all kinds of indices from the simulation model. Just a quick refresher here to fix ideas. Here's a picture of a survival curve with life expectancy. Every person year lived is considered a 1, and if you're dead, you're a 0. The idea of Hale is that if you're kind of yucky, you're not fully healthy, that life year is going to count for some fraction between 0 and 1. So the HALE is the weighted average area under the survival curve where the weights correspond to how dark the gray is. There are lots of variables on the National Population Health Survey. We've focused on a subset of them. The first 8 on the left are the dimensions that I just mentioned of the Health Utility Index. In addition to that, we're focusing on things like income and leisure activity and all that. So the risk factors here range from the conventional, body mass index and smoking, to the distal, education and income, to more novel, for example, Antonovsky's sense of coherence. For each individual in this longitudinal survey, we put together 3 tuples. There could be more than one, and typically there were more than one of these 3 tuples for each individual. And we estimated a 2-period lagged Markov kind of process here. So you see some X's and Y's at t-4 and t-2 and t, and a bunch of arrows. So for every arrow, there was a regression. In the case either binary or ordinal logistic regressions in case of the ordinal and binary variables, and quantile regressions for the continuous variables. And in order for the simulation to work, everything's all in one box here. It's a recursive process synthesizing one of these individual level biographies. Anything that turns up on the right-hand side of the equation has to have another equation where it is the dependent variable. And my colleague Jeff is not at all bashful about letting the computer run. So we ran jillions of equations. Indeed, there are over 46 million coefficients for each sex. But not to worry, we didn't actually inspect each of these coefficients. They were designed explicitly and from the beginning to plug into the simulation model. To give you an indication of the kind of results that we get from this analysis, here's a picture of the effects of mobility, 2 waves earlier, 1 wave earlier on the current wave, on your chance of dying. The upper pair of panels for men and women show the lagged effect, and the current effect, actually T-4 and then T-2 in the bottom pair. And you see, or you don't see, but I will tell you that there is a regression for every single year of age from age 20 to 100. So there's 81 regressions in each of those panels. But you also see some sort of vertical smear there. And the good news about the National Population Health Survey is it included bootstrap weights. So we ran each regression 40 times for each of 40 different bootstrap weight replicates. And so there's about 6,500 equations that you're looking at on this one slide. And let me also draw your attention to the fact, first, it's obvious that the more recent mobility variable had a bigger effect on your chance of surviving than the lagged one. But there's the pattern with age is not linear, it's not exponential, it's not log linear. So the idea of actually running it by single year of age, in parentheses, actually was kind of a kernel with adjacent ages included, really allows us to capture much more precisely the variation in these effects. So the result, as I said, is this 40 million, or actually 80 million coefficients. Most of them were 0, 80% of them were 0. On the other hand, there were about 1% of them that had very strong effects. Now, one way to think about this massive exercise in statistical estimation is that we're taking a longitudinal survey and we're not making up data, we're transforming it into a form that can be used by a simulation model, into a form that's more amenable to be used for analysis. So here are the first results I'd like to show you. These aren't from the model, these are from the NPHS itself. It was linked to mortality follow-up, so we can see the mortality rates for women on the left and men on the right. And the fact that there are those vertical streaks represent the 40 bootstrap weights. They're kind of like a 97.5% confidence interval, but it's really a prediction interval. And now, okay, here are the hazards as estimated using our simulation model. And remember that the observed data are really a mixture of cohorts born between 1900 and 1976, whereas the simulation model is this sort of 1976 birth cohort following sort of 94 to 2008 dynamics. So they're not quite conceptually identical. Here's the average health utility index values by age and sex, and here are the corresponding estimated values in the contrasting color. Again, they're not quite identical. In fact, there's a bit more of a difference that's visible. But again, I think conceptually we have to remember that the simulation isn't quite the same. Call it a semi-period cohort. It's not 1-year data, but it's sort of like 15-year data. Now that we have all the myriad estimated dynamic relationships in the health paths microsimulation model, ta-da, we have our in silico piece of laboratory apparatus ready to start playing with, experiment with. Recall that the estimation process has effectively created a web of causality. There's all these co-evolving patterns with all sorts of lagged and cross dependencies. By the way, reflecting on the Theo's paper, the idea of dependent comorbidities has a different meaning here. And it might be fun actually to say, what would things look like in this framework? So our exercise now is to create explicit counterfactuals, scenarios that are exactly the same as our base one, except for one change at a time. For example, positing that no one ever smokes. Conceptually, this is like snipping one of the arrows in our logic diagram. Computationally, in the case of smoking, no matter what the equation is telling us to do at each period for each individual, we set smoking to never smoked. We just override what the dynamic equations are going to tell us. Given the available time and to simplify the display of our main results, we've collapsed a number of risk factors, both proximal and distal. BMI, smoking, family membership, and employment are used directly, but we've created some composite risk factors for purpose only of displaying the results. If we had more time, I'd show you the underlying stuff for socioeconomic status, physical function, mental condition, and sensory function, which I note includes pain. I've highlighted here by underlining and changing the color of the text those factors that are not in the GBD. So the others are more or less there in the, not directly, but in the vignettes that describe the different sequelae. And so here's the main slide and my second last slide, which shows the results. Now there's a lot of stuff going on in here. So what you see on the left is life expectancy. On the right is health-adjusted life expectancy. In rank order, in terms of the median of the replicates, are the factors, the 8 factors that were on the previous slide. What looks like curves are actually scatters of the 40 bootstrap weight points. Perhaps the most surprising results are the really low values for smoking and body mass index. In the case of smoking, it's relatively low ranking, but it still accounts for almost a year in life expectancy, is because the 76 birth cohort had relatively few had lots of never smokers, many more. For BMI, it's at the bottom, and one conjecture is that when you include a whole bunch of other variables, the omitted variable bias goes away, and maybe that's what's going on here. Not surprisingly, socioeconomic status, physical and mental functioning are very important, but the most dramatic observation is the difference in sensory function between life expectancy and health-adjusted life expectancy. And while the rank order of mental conditions hasn't changed, if you look at where that scatter of points are, where the median is, which I've roughly indicated here, it's more or less tripled in its impact when you look at health-adjusted life expectancy. So let me conclude. Our focus has been on health-adjusted life expectancy as the bottom line health measure. We have also taken on the complexity of understanding population health and its major determinants, transcending what GBD is an exception, but what often seems to be piecemeal epidemiology to explore a coherent network of empirically based dynamic relationships, relationships whose structure has been constrained as little as possible by a priori assumptions such as functional forms or concerns about parsimony. We wanted to let the data speak. And where the data have uncertainties, especially as shown by the bootstrap weights, we have incorporated them. Further, the empirical estimation process has been opened up by the intention from the outset that it would be closely coupled with the health paths microsimulation model. Our health paths model, in my modest opinion, represents the potential of microsimulation methods to move epidemiology away from constraining, simplifying assumptions to richer and more realistic understandings of the evidently multifactorial character of health processes. Thank you very much.
Good afternoon. Over the past 2 days, many of you have spoken about the importance of considering equity in health. I have the privilege of sharing with you today the work IHME has been doing to estimate one dimension of inequality, namely constructing a wealth-based measure of inequality that's comparable across years and across time. One of the projects I've been most involved in during my time at IHME has been estimating maternal mortality for the global burden of disease. When I began that work, my colleagues had just published this paper detailing which countries were on track to meet Millennium Development Goals 4 and 5. While it is a convincing and analytically rigorous piece of work, it leaves one question glaringly unanswered, which is why? Why are some countries making so much progress in reducing maternal mortality while others have failed to see any progress at all? What I'll argue today is that part of that answer is economic inequality. I want to begin by explaining why we began this work in the first place, how we went about doing it. I'll relate inequality back to health in terms of the MDGs, and I'll conclude with where we go from here. To help me explain the motivation of why we began this work, I brought my own panel of 4 men, whose work you're probably familiar with, though whose faces you may not be. The first question of motivation is, why would an institute focused on health want to create an indicator, an economic indicator? This is Samuel Preston, whose Preston curve relating income and life expectancy is arguably the strongest evidence we have relating income to population-level health outcomes. Why then did I say that we created a wealth-based measure of inequality? There's 2 reasons, the first of which is explained by Milton Friedman's permanent income hypothesis, which states that people behave, as in they make purchases, seek health care, are willing to pay out-of-pocket payments, based less on their income, which may fluctuate or be seasonal, but more on what he terms their permanent income, so on the goods that they own, the savings that they have, and the other resources available to them. The second reason is more practical. We base our wealth index off of asset ownership, which is both easily collected in surveys and already available in hundreds of surveys worldwide. The third point of our motivation is, why do I want a measure of the distribution of wealth rather than just an average? This is Sir Michael Marmot, who is both a pioneer in the field of social determinants of health and the leader of the Whitehall studies, which have introduced the idea of a social gradient in health, which is to say it is not just absolute poverty that leads to ill health, but that in fact across the spectrum of wealth, people experience different levels of health. So how am I going to capture that spectrum of wealth, that distribution, in just one number? This is Corrado Gini, whose Gini coefficient captures the difference between an actual and a totally equitable distribution of wealth. In order to construct a Gini coefficient, we take all of the individuals in a population, we arrange them from the least to the most wealthy, and we plot the cumulative share of the wealth that they own. In a totally equitable society, this would be a 45-degree line, where 50% of the population owns 50% of the wealth. In many countries, however, we find that the distribution is something more like the red line, where 50% of the population owns only 25% of the wealth, or even less. The Gini coefficient captures the difference between the actual and the totally equitable distributions. It's calculated as 2 times that green area. Now, we do already have estimates of the Gini coefficient. Pictured here are the World Bank's Gini coefficient estimates for the past 5 years. But there are 2 challenges we hope to address, one of which you can see here and one of which you cannot. What you can see here is that there are large gaps in our knowledge. So in the past 5 years, we don't have estimates of the Gini coefficient in most of the world. The second thing which you cannot see is that these Gini coefficients are estimated in inconsistent ways. Some of these estimates are based on income, and some are based on expenditure. We hope to address both of these challenges by creating our own wealth-based inequality index. We did this in 4 steps. First, we created an asset-based wealth index within each survey that we had. We then made these within-survey indices comparable across countries and across years. From there, we converted them to a unit that we can make sense of, or dollars, and then we can construct any inequality measure that we want. For the purposes of this presentation, I'll discuss just the Gini coefficient. The first step, creating a wealth-based inequality index within surveys, we identified 477 surveys from 141 countries that were both nationally representative and had the 2 types of information that we needed. Those 2 types of information were first asset ownership, and when I say assets, I mean things like goods, like televisions, Things like dwelling characteristics, like what sort of material the floor is made out of, and access, like does the household always have access to electricity? We also collected information on household characteristics, like whether the household was located in an urban or rural location, how many people lived there, and how many years of education the most educated person in the household had. Given this information, we then run our DIHOPIT model, which stands for dichotomous, hierarchical, ordered probit, and is less intimidating than it sounds. It is a Bayesian estimation process from which we get a household estimate of permanent income, of wealth. At its core, though, it is a probit regression of asset ownership on those household characteristics. What we get out of that regression is two pieces of information. The first are the coefficients on those household characteristics, on that urban-rural, that inform our prior, our best guess. So given that we know a household is urban, with 6 people living there, our best guess of their wealth is this. The second piece of information that comes out is an asset cut point, or a value of wealth above which a household is more likely to own an item than not. Let me show you what that looks like visually. I have as an example the Afghanistan 2010 Special Demographic and Health Survey. You'll notice that our y-axis is wealth. It's currently unitless, and for the time meaningless. We'll come back to that. On the left-hand side, I have all of our asset cut points plotted on one graph. And so, for example, we can see that in Afghanistan in 2010, a household was more likely to own a refrigerator than not if their wealth was above 0.8. When we combine this information on asset cut points, the household characteristics, and what assets a household actually owns, we can make our final or our posterior estimate of that household's wealth. When we plot all of the household's wealth in a survey, we get the distribution seen on the right. However, the question I most often get when I try and explain this work is how could you possibly make an asset-based measure comparable across countries and across years? Because owning a boat in a landlocked country means something completely different than it does in an island nation, and owning a cell phone today means something very different with regards to wealth than it did 20 years ago. And in fact, both boats and cell phones are not really comparable assets. However, there are assets that we can identify to anchor our translation between survey and global indices. These both have to show up in many surveys, and I say here that they have to exhibit similar ownership patterns in different countries and different years. What I mean by that is that as you increase in wealth, do you increase in the likelihood of owning the asset? Again, to show you this visually, that Afghanistan 2010 survey, on the x-axis, I've taken all of the estimates of household wealth. I've parsed them into all of the households into 20 equal-sized bins and arranged them by wealth. On the y-axis is the proportion of households within each of those bins that owns the item. As you can see, as you increase wealth, you increase the likelihood of owning the item. And in economics, this is termed a normal good. And we find that, in fact, a refrigerator is a normal good, also in Bangladesh in 2010 in the multiple indicator cluster survey. And similarly in Cote d'Ivoire in the 2005 AIDS indicator survey. So if we can identify all of the assets that are normal goods across countries and across time, we can use these to anchor our translation between survey and global indices. In order to do that, we take the average value of each of those anchoring assets. We take the average value of their cut point to get our global cut point value. We then pair those anchoring assets that show up in a survey with the global average values. We run a regression of the cut point values against the global cut point values, and those regression results are used to transform each of our household wealth estimates to the global scale. The problem is that we're still working in wealth space, which doesn't make much sense to us, so we need to convert it to dollars. Thankfully, if we take the average wealth estimate for a survey and we compare that to the income per capita in that country and year, there's a remarkably strong correlation. So we can just do a linear transformation to go from wealth to dollars. Once we have that, we can make any traditional inequality measure from these estimates that we would like, including the Atkinson index, the ratio of the 90th to the 10th percentile, and again, we'll focus on the Gini coefficient here. We finally created a time series, but we only used countries for which we had data because we wanted our estimates to be empirically based. What results is a picture of inequality worldwide that's pictured here. We see the highest levels of inequality in Namibia, South Africa, Bolivia, and Peru, and the lowest levels in Palestine, Ukraine, Uzbekistan, and Belarus. You'll notice that we do still have gaps where either we have not yet prepared or have not yet identified surveys that are both nationally representative and contain the information that we need. but we hope to address that with future work. Also, given that we've created a time series, we can examine inequality in a different way. Here we've defined a significant change in Gini coefficient from 1990 to 2010 as a change in 1/2 of a standard deviation of the Gini coefficient, which works out to be a change in Gini coefficient of 0.05. Those 13 countries pictured in orange have all increased their inequality, increased their Gini coefficient by at least 0.05, with the highest increases seen in Namibia and Yemen. In contrast, those 30 countries pictured in green have seen a decrease in Gini coefficient, a decrease in inequality of at least 0.05, with the largest decreases seen in Kazakhstan and Myanmar. With a time series, we can also begin to relate inequality back to health. In particular, I wanted to see whether inequality levels in 1990 were predictive of a country currently being on track to achieve MDG5. In practice, this meant constructing a logit model, where the outcome of interest is a country being on track to meet MDG5 or not, with Gini as the predictor of interest, Gini coefficient in 1990 as the predictor of interest, while also controlling for income per capita, education, and HIV. What comes out of a logit model is a probability of success, a probability of a country being on track to meet the Millennium Development Goal target. The current average probability of success, we can also just calculate as the 10 countries of the 141 that were part of this analysis that were on track to meet MDG5. We can construct a counterfactual scenario in which we hold the income, education, and HIV levels currently seen in every country constant while reducing the Gini coefficient by 1 standard deviation, by reducing it by 0.1. We then nearly double the average probability of success. So we would expect that 19 of the 141 countries that we have done this analysis on would be on track to achieve MDG5 if they've been able to reduce their wealth-based economic inequality by 0.1. We can also construct a scenario where we set every country's Gini coefficient to be a fixed value. If we do this across all values of Gini, we get the picture here, and I just want to point out 2 things from this. The first is that even if within country wealth-based inequality is eliminated, if within country places are completely equitable, we still would not be able to explain the entirety of country's success in meeting MDG5. There's still only about a 50% chance. However, we do see consistently that as we increase inequality, we decrease the likelihood of seeing health gains. We find similar results when we do the same examination with MDG4. There are more countries currently on track to meet MDG4, 34 of the 141 that we have as part of this analysis. But we could raise this to 34%, or 47 of the 141 countries under analysis, if we were able to reduce inequality by 1 standard deviation. So where do we go from here? The first step is to standardize the model. Because this model has relatively simple inputs of asset ownership and household characteristics, this model could be incorporated into subnational analyses so we can begin to make state, county, or even neighborhood level estimates of inequality. Secondly, I hope to use this measure to better inform disease burden estimation. I hope that it's not only used as, for example, a covariate in estimating our cause of death models for the GBD, but also that we can begin to understand and use distributions of wealth to inform distributions of health. Finally, in line with the theme of the conference, which is data, debate, and directions, if we can pair a time series of inequality with a time series of health outcomes, like that provided by the GBD, we add data to the debates relating health and relating economic inequality and health outcomes like heart disease, depression, and suicide. And if we continue to find consistent and significant relationship between inequality and poor health, our field has a responsibility to adjust our direction. In other words, to concern ourselves with measuring, estimating, and reducing economic inequality. Thank you.
So thank you all speakers for excellent presentations. We We now open the floor for questions, and we take 3, 4, 5 questions in a row before we turn them over to the panel.
Hi, Ian Bolliger. Question for Theo and Donald, although probably mostly Donald, since I think I've heard Theo's comments on this a few times. Curious if you looked at correlations between injury outcomes in particular at all in your analysis, because it seems like those might have particularly larger correlations than you might see in other diseases and other health outcomes.
There's one question over there.
Tanya Roberts with the nonprofit organization National Center for Foodborne Illness Research and Prevention. My question also is for Theo Vos, and I was wondering why you excluded observations that were more than 2 standard deviations out. And I was wondering if death was one of those outcomes that would be 2 standard deviations out, or did I totally not understand what you were talking about? And I was wondering the excluded observations, what percentage were they of the total?
Is there a question over there?
Hua Chung from Clemson University. I have a question for the first presenter here. You mentioned about 2 diseases that are dependent or independent, and then you use the word correlation between 2 diseases. I don't know if you can address this issue empirically, but from a conceptual perspective, I don't know how I could understand if the 2 diseases are causally related. So let's say disease A causes disease B, and if you have a population of 1,000 people and a number of diseases are causing each other, not necessarily only correlated to each other. So that's the first question. The second question is, you mentioned about a number of surveys, household surveys. Would you also use clinical data to look at the relationship so that you can say more about the causal relationship rather than just the correlation? Thank you.
Okay, shall we, maybe you, Theo, begin?
Okay, about the correlation of injury categories, I didn't pick up examples. We have them for all the categories that we included in MAPS, and all the injury sequelae were virtually indistinguishable from between the dependent and independent measures. So not a good example justifying our choice for independent comorbidity corrections only. But I would have expected more, particularly because a lot of injuries co-occur and that having an effect. The question about the exclusion, that was in that particular little survey of the IHME staff filling in the SF12. We decided to cut, and it was on the slide, 18% of the observations that had values of 2 standard deviations either way. I think if we would have included that, it would have created more noise, but I don't think the pattern of the regression line would have changed a lot. I don't have a slide to show you that.
Don?
With regard to injury correlations, we didn't have data in the surveys to address that question. But one of the things that I've been concerned about is that not only do some injury patterns co-occur, but there are some injuries which in some sense preclude other injuries. So there would be a negative correlation which would slightly increase the degree of YLD. So that's an open question. As to whether or not the diseases are causally related, no, it's not the case that we need to make any assumptions about causal relationship. It's only co-occurrence that's important. I would assume, generally that there was an explanation for why there would be dependence between two or more diseases, but there's no need in this kind of analysis to speculate what that might be. With respect to clinical data, gee, I'd love to be able to use it. The closest we're going to be able to get in Canada is to strongly examine administrative data, notably the roughly 35 million doctors' visit records that we obtain in Alberta each year. Now, that's going to put a big challenge on building algorithms for claiming whether a disease is present or not, but we certainly look forward to trying.
Just to add to that, in the comorbidity work on the Australian Burden of Disease study, we populated the matrix of correlation factors. We did that at the level of diseases using survey data where we could, and where we didn't have survey data for the right conditions and combinations of conditions, we turned to hospital admission data, even realizing that they are probably poor proxies for some of the combinations. That was the best that we could do, and then ran a dependent comorbidity correction. Unfortunately, we never looked at what it would have been if we had not taken the dependent comorbidity into account, so I can't report on that.
Are there any more comments from the panel, or we have more questions over there?
Thanks very much, Richard Horton from The Lancet. Question to Nicole, well, a comment and then a question. Comment being the whole thrust of global action on MDGs 4 and 5 has been around interventions. The Commission on Life-Saving Commodities, Family Planning 2020, a promise renewed. Your work opens up an extraordinarily exciting new avenue of thinking about how we might accelerate progress on 4 and 5, especially when we think about the post-2015 agenda. Two brief questions. First, I wonder if you've actually discussed your work with any of those agencies and programs that are thinking about accelerating 4 and 5 over the next 2 years, because I think your work is immensely important and relevant to thinking about those. I would encourage you strongly to make contact with the Every Woman, Every Child initiative. Very important. And second, I wondered if there's a way of combining your ideas with the focus on commodities and interventions. Is there a way of looking at the relationship between the inequalities that you're modeling and the impacts that they have on 4 and 5, with also distributions of commodities, to see if we can, in some sense, because if you're thinking about you're going to countries, and at the moment we're focusing exclusively on just getting a commodity to a person, but if you could put it in the broader socio-economic context that you're doing, then you then have a package of measures that would be extremely useful. I wondered if there's a way of linking those two agendas in some way, but fantastic work, really exciting.
One more question over there.
I think Dr. Hagopian has been waiting for a while.
Okay.
Amy Hagopian from the University of Washington. Just to follow up on what Dr. Horton said, my comment was going to be, I thought Nicole's presentation was truly remarkable. And if I understand correctly, we could make a 50% improvement in MDGs 4 and 5 simply with a public policy change around distribution of resources without having to battle a single microbe that we don't understand. That's truly remarkable.
Next question.
So this is Nadine Chan from our local Seattle King County Health Department, and also a comment on Nicole's presentation. I was curious if you could comment on if are you aware of folks who may be exploring this at the neighborhood level, using the Gini coefficient as a predictor of health outcomes? And the other question that I had for you related to that is, could you comment on some of the limitations of using this, either limiting it to income only or doing the asset-based?
Okay, one more question.
So Zulfi Bhutta from Aga Khan University. So I was also very fascinated by Nicole's presentation, and it actually takes me back to what we published in 2003 as part of the Child Survival series on the thought experiment of how many lives could you save by just switching the rates of deaths, what were encountered in the poorest quintiles as opposed to the richest quintiles. And what you presented is quite similar to what was said at that time. So my question to you is much more specific on how do your estimates of the impact of reducing inequality compare with what has just recently been highlighted in The Economist in terms of the overall reduction in poverty over the last decade and its relationship to national policies of income distribution where their data were available, and also on growth rates within countries. So do you see in your own estimates any comparability with what two independent groups have published recently?
We'll take your question as well.
My name is Diego Gonzalez. I'm also from IHME. Sorry, Nicole, I'm not going to give you a break here. Mine's for you as well. There's a series of development economists, at the least Ananda de Soto, have linked land assets or property rights to household wealth. Do you see an opportunity, perhaps a challenge, or is this confounding to try to include land assets in your assets-based estimation of Gini coefficient?
So Nicole, it seems like a long string of questions to answer.
Okay, great. Thank you all for that feedback. Sorry. First, to Richard Horton's point, have I talked to other agencies making the decisions about the post-2015 agenda? I have not. I've talked to my colleagues that are working on similar work. If any of you in the audience are working on that, I would love to talk to you about that afterwards. A lot of these results we've actually only come about in the past few weeks. So this is still sort of preliminary work, but I would certainly love the opportunity to begin exploring the implications of it. To the woman from King County, I'm not aware of anybody currently using the Gini coefficient at the neighborhood level. If you're interested in doing so, again, I'd love to talk about that. You also asked about some limitations of this measure. In particular, I just want to talk about the limitations of the Gini coefficient, which is particularly oversensitive to changes in the middle of the distribution, and it may not capture changes at the extreme. So we'd also want to explore whether this relationship holds when we examine other measures of inequality. To Diego, to also including other measures, other sorts of assets, I think that could certainly be possible at the individual survey scale. For the metric that we've produced here, that data just isn't available in all 477 of those surveys. So I think for the global sort of time series that we've created, that's not possible, but in a case-by-case basis, that could be.
I don't know about the global situation, but in the OECD countries, and particularly in the US and Canada, there's a long, couple decade history and lively debate about the relationship between inequality and health measured in a variety of ways. One of the concerns is putting inequality on the right-hand side of a statistical analysis, which is an ecological variable when you don't also include some measure of socioeconomic status at the individual level. There is some evidence, yours truly has contributed to it, to suggest in the US that even when you control at the individual level, income inequality among states still matters, but this is an area of a lot of debate.
Are there any more questions from the audience? No? If before closing, I would like to take this opportunity to inform you about, as I'm relatively new to this field, as I learn more and more about GBD and the wealth of information that I've collected on mortality, on morbidity, and on risk factors. There is also one important box on the flow chart of the GBD. It's called the covariate database. And Earlier this morning, we heard about a very impressive time series of tobacco smoking for 187 countries for over a 40 years period by age and sex. And now we learn of Nicole's work on permanent income, which will hopefully enter the covariate database later this year. And there are not only data on risk factors, but country-level indicators outside the health sector, and many of the socioeconomic indicators that people miss from the GBD, they are in the covariate database. And I think it's a very important source that open up the possibilities for a new generation of important country-level ecologic analysis. Before we close the session, I also like to make an announcement from that there will be an open house at the Institute for Health Metrics and Evaluation starting at 5:30 this afternoon until 8:30, and it's in the IHME Belltown offices, which is a 5-minute walk down 5th Avenue. And if anyone don't know the direction they should walk in, there is a map in the program. So I want to thank the speakers for excellent presentations, very important work, and the audience for listening. Thank you very much.